For those of you that don't know me, I'm Elizabeth McCauley, and a lot of people, I feel like I have a little bit of a paid audience here. A lot of these people I work with, I appreciate you coming. I hope I say something new and different that will be of interest to you. Okay, so anything else I need to do? I'm looking from the bosses back there. Do I just get started? Anything you need to announce? Any disclaimers? Oh, I know, I need to get here. So I'm going to cover a pretty broad swath of territory today in hopes of kind of outlining some of the critical issues that we are currently dealing with when we think about depression, treatment for depression in adolescents. I would like to have this be interactive, so as much as we can, if you want to interrupt with a question, and if I feel like we're kind of going down a certain pathway that is going to take up too much time or get us off track, I'll kind of head us back in that direction. But do feel free to interrupt with questions and comments and disagreements and arguments and all that kind of stuff. So first of all, disclosures and acknowledgments. The work that I've done in the area of treating depression and working with depressed adolescents involves a whole host of people, many of whom are in this room, many of whom I owe endless debts of gratitude. It also involves a big staff of folks who are our clinical interviewers and our research team, and I apologize that not every single person is up there, but we would have it would be too crowded of a slide. And then, of course, we have to acknowledge NIMH and the Seattle Children's Hospital that has funded our work, and the Institute of Education for Education Sciences. And my one disclosure is I have a contract for a manual on behavior activation as a treatment for adolescent depression. Soon to be done by the end of this month. I promise. This is public, whatever you're supposed to do publicly to make sure something gets done. So here are my goals, and we can sidetrack to your goals as you want, or if I feel like I know something to say for your goals. I'd like us briefly to consider the evidence regarding the need to enhance treatment and treatment outcomes for adolescent depression, and outline a series of other strategies that we've kind of done some work in and I think need to be considered as we move forward treatment for adolescent depression. So those include access, increasing access, changing the way that we think about treatment in terms of our treatment targets, our treatment strategies, and our assessments, integrate developmental neuroscience into our treatment approaches, and consider new approaches to treatment design and implementation, study design and implementation. So I think the new wave is to have very few slides and very little on your slides. I'm of the old wave, but I'm working towards the new wave, so next time you see me, I'm going to show 3 slides with 3 words, and that'll be it. Not today. Okay, so where have we been and where are we going? We now have, I'm assuming that many of you have come to other of these lectures, and the focus of these lectures is to talk about the huge and very promising and very encouraging evidence base we have for effective treatments for children and adolescents. I'm going to take a little bit of a sidestep on that. I'm a firm believer in evidence-based practices, but I think we've run into some snags. So first of all, it's a challenge of uptake, and I think others have probably talked to you about that there's a huge gap between when an evidence-based treatment gets developed and tested, and then tested, and then tested, and then tested, and finally makes its way out into people's practice, if it makes it out into people's practice at all. So 17 years for just 14% of original research to benefit actual care. We know that there's a big attenuation effect of evidence-based therapy interventions when they get to the field, they get to the real world. That's a challenge to us. I don't think that's something that we can put off on the people who are out there practicing. We need to make the work that we do accessible, real, practical for folks. It's unclear what actually treatment as usual conditions. So a lot of research studies compare an evidence-based intervention with treatment as usual, but it's kind of a black box. What is treatment as usual? What does that really mean? And I I think that many people would be incorporating components of evidence-based practice into what we would think of as treatment as usual, and how are we assessing and managing and monitoring and taking that into account. So then I think probably for me, one of the most sobering things is that John Weiss, who has been, he's a psychologist, he's at Harvard, he's, I would say, been one of our just leaders in this whole evidence-based practice field, somebody that we all emulate and really like because he's a really nice guy. He has led the work, and then in 2013 he published this meta-analysis, which kind of made us all, at least in the depression world, step back and say, whoa, we've got to be a little bit more cautious. We can't be on our high and mighty soapbox and say this is what people should be doing, because in the meta-analysis, the evidence-based practice advantage was modest, not super duper, and it was moderated by many factors, one of them being the severity of the kid's presentation. Now, I sit at a children's hospital, I get kids off an inpatient unit. We're dealing with kids who have severe psychopathology, so we need to have interventions that are effective for them, as well as maybe a kid that we might see in the school who's presenting at the very early stages of where we could do some prevention intervention. So in the big picture, I think we have to recognize that we've not made a lot of progress in the big ticket issues, if you will, reducing rates of mental illness, improving psychosocial function. There's a really very interesting paper, and I was able to attend with many of you Shannon Dorsey's talk about her work overseas, and I think she brought home this issue. We have to really be focusing on function. Are we making a difference in how people are functioning? If we can get somebody to report fewer depressive symptoms, that's not a bad thing, but if they aren't going to school, if they can't do their homework, if they aren't comfortable with their friends, if they aren't feeling good about who they are and what they're doing, we have to be thinking about that as well. And then, so we really have to increase access to care is another. So my argument is that we have to rethink a number of things about our treatment, certainly models of treatment delivery. I'm going to quickly go through, and happy to slow down if people want this, or happy to send you slides if you want it. Just a little, because this is my area of research, I have to do a little justification of why are we doing this, why is this important. So adolescence is a vulnerable period for the onset of depression. 8 to 20% of all youth in Kessler's epidemiological studies are reporting significant symptoms of depression. The one-year prevalence is 3 to 8%. The National Comorbidity Survey suggests that at any one point in time, we're going to get about 14.1% of 13 to 18-year-olds who are reporting significant symptoms of depression. Lifetime prevalence, that really means, lifetime is such a lovely thing to think about with these kids. It means up to 18. It's not a long lifetime, but up to 18. Cumulative prevalence is 15 to 20%. And 65% of adolescents surveyed report some depressive symptoms. Now, we might say, okay, that argues that depression isn't just a normal part of adolescent development, and I wouldn't step back or I wouldn't counter that argument. Where we find the risk is that many of those kids who are subsyndromal, if you will, who don't meet any kind of clinical or diagnostic cutoff, eventually kind of move forward and develop depression. So we can't, a full-blown clinical depression that's interfering with their ability to get on with their lives, to have fun, to be productive. So we need to be considering the fact that depressive symptoms need to be attended to, not necessarily labeled or pathologized overly, but attended to. So then the ramifications, I think, are straightforward. If you're depressed as an adolescent, you have an increased risk of substance use disorder, social and cognitive impairments. The mean length of episode in a number of studies can be about 9 months. 9 months is about an academic year, and so you can lose a lot of time academically. Suicide is highly associated with adolescent depression. It's associated with other problems as well, certainly substance use, certainly impulsive behavior. but suicide is now the second leading cause of death between the 12 and 17 age range in our population in the United States. There's a tremendous increase of depression among increased risk for depression as you move into adult life. So if as an adolescent you develop a depressive disorder, your risk for later depression, recurrent depression is increased. And then there's the cost. There's a huge cost to us as a society for paying for the care, paying for the lost productivity, et cetera, related to depression. Thank you. So what do we need to do to enhance our treatment efforts? So first of all, I've already talked about the fact that depression affects a pretty large group of youth. Among those youth, and I would say this is kind of a cup half full, cup half empty, and there's a lot of things here that you'll hear cup half full, cup half empty. So we've made progress. I'm pushing for more progress, I guess, or pushing that window a little bit further. So Costello did a study in 2014 and found about 60% of youth who are presenting with significant major depressive disorder kinds of problems are getting treatment. 60% is pretty good. It's not perfect, but it's pretty good. I think if we did a lower cutoff for kids who are struggling with symptoms of depression but not quite into the full-blown clinical category, we'd see that many of them could benefit from intervention but aren't getting it, so a larger number. The other reasons to enhance treatment, so one is enhance our access. The other is really thinking about the nature of our care. I'm going to talk a little bit about efficacy and effectiveness in the next slide, but I think one of the points that has been really frustrating to most of us who do depression treatment research is that about 25 to 50% of depressed youth who respond positively, effectively, improve in a treatment trial, have a relapse within a fairly short 6 months to 2 years post-treatment. So whatever we're doing, it may be effective in the moment, but it isn't necessarily holding those kids in the long run, and we could and need to think about what can we do that would be better. And that may be a different treatment model. That may be repeated courses of short-term intervention. I don't feel like I have all the answer to that, but this 25 to 50% of relapse is really a target that we need to take seriously. And then there's a whole bunch of kids who stand out as poor responders to treatments for depression, existing treatments for depression. And I think as we go quickly through this list, you'll see this is a pretty core group, pretty critical group of people. So first of all, younger or less cognitively mature adolescents don't respond as well. They don't even respond as well as pre-adolescent kids to some of the cognitive behavioral and behavioral interventions. Youth reporting high anhedonia, and we define anhedonia in our work as social withdrawal and loss of pleasure in activities, not kind of melancholic depression, which has a lot of vegetative symptoms. But high anhedonia are kids who don't respond well to treatment. If you are very high on anhedonia when you go into treatment, it means you're going to need longer. The data suggests you'll need longer treatment, take a longer time to respond. History of altered neurocognitive functioning, so kids who have had some kind of accident, insult, born with some kind of a significant learning disability, all of those kids are documented as responding not as well to our current depressive interventions. And then a history of interpersonal adversity. And I could go on and on about that, but I won't. But there are a huge number of kids that we see who have a history of interpersonal adversity. Interpersonal adversity means early histories of abuse and neglect. So this is a huge population of youth who are not responding well. Those kids don't respond well to medication. They don't respond well to IPT, interpersonal psychotherapy. They don't respond to CBT. They are a challenging group of kids to work with. Okay, so in terms of the nature of how effective or where do we stand in terms of efficacy, effectiveness, when I I've been doing this work for a long time, and early on in this process, I think we felt like we have got this cooked. We are really doing well. We are CBTers up and down the wazoo, and that is all you need to do, become a good CBTer, and you're home free. We had effect sizes back in 98 of 1.02. That's a really good effect size. As a person, as a researcher, I would be so happy to have that effect size in my work. Then in 1999, it was 1.27. Woo, that's even better. By 2002, more trials, effect sizes getting a little bit smaller, but personally, I wouldn't complain about 0.72 as an effect size. And then John Weiss, the person I referred to before, did a meta-analysis that he published in 2006, published with one of our colleagues, Carrie McCarty, who's my colleague in pediatrics, and probably some of your all's colleagues as well. And that was 35 trials, including the TAD study, which is the largest. It's a treatment for adolescent depression study. Has 439 participants. That's a big study, hard to do. And then 2 IPT trials, so the interventions that we think are most effective. And they got an effect size of 0.34. So then we're back into eating humble pie. What are we doing? How good are we at doing it? And then Cox did one of these big time meta-analyses where they looked at 10 different trials, 1,200 kids, and what were we getting in terms of effect size, and did we have one treatment approach that really stood out? No difference between treatment approaches, and approximately 54 to 68% remission following acute treatment. Now again, that's one of your cup half full, cup half empty. I think 68% is pretty good. 54, then I'm beginning to worry, what are we doing and how are we doing it? So I'm hoping that I've convinced you that this is work that's worth doing, that you aren't thinking, well, I already know how to do CBT and I'm good at it and that's what we need to do for adolescents who are depressed. I would argue that's probably good for some and keep doing it, but also be thinking more about what we need to do. So we have effective treatments, but treatments are not working as well as we want. And so what are some of the barriers? We've talked about the fact that the translation of evidence-based practices into the community has its own challenges and is fraught with some difficulties. Related to that is this issue of the need to demonstrate functional versus just symptom reduction outcomes, and very little research has included that, even adequate measures of functional outcomes. So that's something we need to be thinking about. Another point is the complexity of treatments, and again, a lot of the treatment manuals that people are asked to learn are complicated, difficult to master, difficult to follow in the day-to-day, real-life clinical world when you can't predict how the kid's going to come in, what's going to be going on, what might have happened at home, and so it's hard to say, okay, great to hear that you're dealing with all those challenges so well, we're sticking to the next activity in my manual here. So there's a lot of flexibility that people need to be ready to use and jump on their feet to work through. And then I think another big issue that's particularly important for depression is the heterogeneity of the youth. So first of all, the DSM criteria for depressive disorders have low diagnostic validity and specificity. So we are using a cluster of symptoms which many kids will fit into, but I think we have to challenge how useful they are. What are they really telling us? The diagnostic boundaries are unclear, and you'll see that in the next point. 40 to 90% of kids have a comorbid diagnosis. So what does that say about a depressive disorder? What is it really? What does it really mean? What does it really reflect? So we have heterogeneity, and in some other disorders or some other problems, I'm not really very much of a disorder person, but in some other problem areas like anxiety, we have done a better job of subclassifying and detailing kind of, this is a person who has school phobia, this is a person who has panic attacks, this is a person who has OCD. And I, as a clinician, have some specified interventions to fit those kind of problems. We have not yet done that for depression. So the depressed kids come in one big basket, but they are very different. The heritability of depression is not very great, 0.20. That is not very great. That means there's a lot of variability accounted for by other things other than your family. Temperamental factors play a role. Certainly how, if you are born with a more negative, more reactive, more irritable temperament, that's a risk factor, but we don't know how much that accounts for, and that's variable across kids. We have a lot of noise in the environment, this exposure to early adversity. We have a lot of focus on stress overload, which we know is a very general concept and is going to vary widely from child to child. Social rejection is, I'll talk a little bit more about that, but social rejection is kind of emerging as a major theme in adolescent depression as a trigger factor to trigger a depressive episode as youth get rejected by another person in their environment, as opposed to just general psychosocial stress. So if I get dumped by my boyfriend, that skyrockets my risk, as opposed to if I have a fight with my mom, or if I have if another one of my friends even moves away. It's that personal rejection thing that's going to be a major risk factor. And then we know there's things about the adolescent's brain that makes it different from our brains and from little kids' brains that we have to be mindful of. So I just wanted to give you a sense of these are three kids all made up to be the same age, but you all know these kids, I know these kids. So 15-year-old boy with history of ADHD, trouble with peers, school challenges, becomes increasingly sad, irritable, socially withdrawn, and discouraged. That's one kind of depressed kid. We call that the dual failure kind of model that people have talked about. Then we have a 15-year-old girl who's popular, good school performance, but sensitive, always sensitive, becomes emotionally hyperreactive, euphoric, agitated, restless, with difficulty sleeping, rumination about her peer interactions, and begins to cut to reduce negative feelings. That's probably a category we would call atypical depression if you're thinking about diagnostic categories, and it's a very common presentation in adolescents. And then a 15-year-old boy who has been a solid student, active with peers and in sports, begins to withdraw from activities, skip classes, avoids friends, describes himself as tired all the time, bored, unable to sleep, thinking a lot about death and the meaning of life. Another kid, again, I've seen this kid, I bet most of you have seen this kid. We can't use the same Band-Aid. We need different Band-Aids for these kids. The fact that we think we can treat them all with the exact same set of tools, I would challenge that we need to be thinking a little bit more broadly. That last kid is a kid who we would think is high in anhedonia, so that's your anhedonic subtype. So I'm going to run through probably really quickly. Somebody else is going to have to watch the time. Eric, will you tell me when I'm maybe have 10 minutes left?
10 minutes, you got it.
Okay. Or when I'm getting close to 10 minutes?
1:30? Okay.
Okay, good. I'm going to run through a number of different strategies, and I may go a little bit rapidly. I'm going to go more quickly through some of them than others of them because I think that they're pretty broad strokes, and I just want to kind of get you thinking about what are the things we can do to improve our treatment work here. So strategy one is changing where and how we provide services. So Eric and a number of people in this room have been involved with me in doing some work where we have been partnering mainly with Seattle Public Schools, now with Issaquah, to test a brief step care model designed to fit the unique needs of the school setting, so getting out of the clinic and into the schools. You're probably not an audience that I need to go through, and I cut out all my slides about why it makes sense to be in the schools, i.e. the kids are in the schools, the kids across socioeconomic and ethnic groups are in the schools. You can put in a little request to report, and they come to your office and talk to you in the schools, so there's a lot of reasons clearly to be in the schools. But school mental health care providers, and there's a whole variety of them. There are people who come from public agencies and go into the schools and provide services. There in Seattle, we are fortunate enough, and parts of King County, to have school-based health centers, so we have mental health folks that are in the schools. But all of these folks tend to be a sole practitioner in a building, have a large caseload, have frequent disruptions, and a lot of the things they're asked to do by school personnel are crisis-focused, take care of this problem, put out this fire, get this kid back in class, get this kid out of class, just kind of keep things going smoothly. They have engagement difficulties. In part, it's kind of the pros and cons of being in a school. So if I am a parent and I want my kid to go for psychotherapy, then I'm the kind of parent who I might pick up my kid after school and get him to that appointment. But if my kid can go or not go in the school, even if they have a scheduled appointment, those of you that work with adolescents know that if anything better comes up, they're going to that better thing. That better thing could even be, skipping class. So it's hard. Engagement issues, they have a lot of freedom to engage or not engage. I think it's a good thing, but we have to be mindful of the work we need to do to engage. Up to 60% of students in schools present with subclinical presentations, and that means that maybe our interventions need to be different, certainly our attitudes need to be different, and our opportunity is huge because we have this huge opportunity to do preventive interventions, early interventions, to head things off very quickly. And most students attend 4 sessions or less, so the schools aren't going to be your long-term outpatient treatment model setting for the most part. So we've developed this brief intervention that is designed to have 4 sessions. We're going to be flexible about that. And I just want to present, it focuses on teaching kids problem solving, doing a top problems, kind of problem list approach. I'll talk about that in a minute. Teaching kids some problem solving strategies and trying to really focus on teaching them how they might effectively solve a doable, small even, problem in their daily life as a model for how that might scaffold them the skills they need to solve bigger problems. So we're not trying to take on everything in their life, just a small problem. And we see it as a step care model, which means that some kids clearly at the end of this would move on to additional care, but many others don't move on to additional care. They might need another service in the school, but not necessarily long-term mental health care. Remember, 60% of them don't have a mental health diagnosis, so we're really just facilitating, what do you need, how can we help you, let's get you there. Preliminary data are promising, and that pilot only in red is imperative because this is very preliminary. I don't even have the data from our second year of the study, so this is very early on. Point being, we need to think about where we're doing the work that we're doing. The second example of the strategy one, changing where and how, is the collaborative care with adolescents with depression, doing treatment in primary care. And we've just finished a study that was a collaborative project with group health, where we went into 9 primary care clinics in the group health system in Western Washington and provided a very brief, structured but brief CBT for depressed kids who were presenting in that setting with what we call a depression care manager. So there was a person located in that setting working with the pediatricians or the primary care docs, getting referrals from them, and seeing the kids right in one of the treatment rooms, right there in that facility. So the kid didn't have to go someplace else and could literally be taken by the PCP to the therapist if that was indicated or desired. The recruitment strategies for this included depression screening, which we were able to do predominantly because we were in group health. Group health is a system of care that allows you to do things that are that are hard to do in the real world, I'd say. And then physician referral, and we had 100 kids randomly assigned to depression care manager and treatment as usual. For those of you that aren't informed or knowledgeable about collaborative care, it's got a very set structure. It was developed here at the University of Washington by a beloved colleague of ours who died just a week ago. So in honor of Wayne, we're going to keep going with our collaborative care work. It includes an education and engagement session for the teen and parents. That's actually something we added. And then it uses evidence-based treatments, antidepressant or brief CBT, delivered in the clinic, treatment selected by the teen with the parent input. So the teen could start on medication if they wanted. They could start with CBT. Most wanted to start with a CBT. Many eventually had medication as an adjunctive treatment. The care manager is the depression care manager. The person's doing the therapy, calling them up, following them up, dogging them, if you will, to get them into care. And then that person had weekly supervision by a psychologist and a psychiatrist. And then there's regular communication between the depression care manager and primary care team and the parents. We found pretty significant positive results for this in terms of outcomes with significant improvement in depressive symptoms. I think that there's an arrow and I should be able to use it. But the red line are the kids who are in the depression care manager cadre. The blue line are the kids that were not. So it's important to note depression went down for everybody, but it went down much more significantly for the kids who were in care. And treatment, I'm going to say a little bit something about, just as conclusions for that. So both studies and settings are focused a little bit on early intervention and prevention. They aren't as, the criteria for entry in the school is if you want help, you get help. At group health, we took kids who were endorsing some depression, but it wasn't like you would see in a clinical study or most of the clinically based studies that you'll read about, or certainly that I'll talk about in a minute. Much higher bar for those studies, much more impaired, if you will, kids. Both studies included, and I think this is really important and maybe the most important message, included ongoing monitoring of responses to treatment that then in turn guided what was happening next in treatment. And as we refine our evidence-based practices, I would say maybe our most important hallmark is keep making sure you're assessing, monitoring change, and then thinking about what you're doing and changing what you're doing in response to what's happening, those monitors of change. If a kid isn't responding, there's no point in keep doing what you're doing endlessly. It's just the simple way of putting it. I think in the group health study, we learned some other things that were interesting and lessons for all of us. First of all, group health, you can get mental health services if you're a member of group health. So everybody who was in the control group in this particular project could have accessed mental health services, and very few did. And they didn't access services even when we reviewed with the adolescent and the parent what we thought were the risks. They were meeting the same criteria as the kids who came into treatment, giving them recommendations to seek care, and very few people sought care. So even when care is available, we need to think about our engagement strategies, how we're reaching out and engaging youth and families into treatment.
Do you know how many sought services and maybe were able to access them within a month or two? Long wait lists or...
Well, because they're all in group health, they have to be seen. Thank you. So the question is how many kids sought services and were not able to access them. And that is the most important question if you're in the general population. But at group health, if you ask for services, they actually have to provide something for you in a fairly quick turnaround. It may not be that you then pick up for weekly therapy as frequently or as quickly, but you have to have something. And most people didn't ask for anything. Yeah. So group health is a rarity in that way. And we thought we would see almost similar levels of people seeking care, and we didn't see that. Okay, so that's only one of my strategies, so I'm going to cook on to the others. So the next strategy is to reconsider treatment targets and strategies, and that's going to integrate looking at NIMH's new focus on the research domain criteria, which means that as opposed to looking at symptoms, we need to be rethinking what are our treatment targets, and as we rethink our treatment targets, that's going to inform actually what we do in treatment. So it's this much more dimensional approach to looking at behavior. So we used to think about depressive symptoms and there was some kind of cutoff and you fell off that cutoff and you were like depressed. Well, what about the person who was like one tiny step away from that cutoff? Weren't they maybe a little bit depressed? I mean, well, how do you make those distinctions? So the new DSM Diagnostics Manual and the NIMH are really saying these things, for the most part, are on a continuum. And so we need to be looking at these behaviors in a continuous way. Dimensional systems. So we're looking at the level of emotional reactivity, our behavioral activity, spanning the range from normal to abnormal. And that we need to integrate classifications, from basic behavioral neuroscience and link that to clinical phenomenon. That's what the RDC want us to do. And they also want us to use several units of analysis in defining constructs for studies. So we used to say, okay, we do a diagnostic interview, you meet criteria for depression, you're in the depression group. Now they really are saying, let's look at this in a much more sophisticated and multifaceted way, looking at physiological activity, looking at imaging, looking at behavior. What are the behavioral indices of depression? Not just what you're reporting, but what are the behavioral indices, and then also self-report. So they're looking at symptoms and function and what the brain is doing. So it incorporates data on pathophysiology, trying to identify new targets for treatment, detect what subgroups are the best targets for what treatments, and provide a better match between what your individual characteristics are and what might be the best, most effective way to work with you to help you feel better. And goes along with that, kind of hand in hand, is doing taking a different approach to assessment. So again, John Weiss, who I mentioned, has talked to us all about taking a much more practical and functional approach to assessment, not relying wholly on these elaborate diagnostic interviews, but also having people say, what are the things you're most concerned about? What are your top problems? What do you want to work on? What's interfering with your life? And taking a more functional approach. We've talked about using behavioral dimensions, looking at basic cognitive skills. There's a lot of focus now on what are the cognitive errors that we are making when we get into a depressed state of mind. So are we really biased in our interpretation of the events around us? That's a much more cognitive process than certainly informed by emotion, but we haven't looked so much at how are we interpreting situations. You can see that in CBT if you think about cognitive restructuring, but we aren't assessing people and how they're approaching a situation and then how they're changing with therapy. And then there's a new focus on looking at implicit association tests, which are those computerized tests where you kind of respond to different, you respond to different stimuli. The idea behind it, the data behind it as well, is that we respond in ways that we might not be conscious of. It's a big thing nowadays in assessing risk for suicide is looking at implicit association tests. Just one example of this is some work done by Pat Arian, who's a terrific psychotherapy researcher who's coming to the University of Washington in the spring. And she works mainly with older adults, but she's done this project which is called Engage, where they really focus just on reinforcing engagement in depressed older adults, focus on assessing and then treating barriers to engagement. Negativity bias is one, that's that cognitive appraisal. Apathy, that's that lack of motivation. And then emotion dysregulation is, I'm just too, getting really upset, kind of the two other kind of overlaps with the others in a way, but getting too upset, I can't do that, I'm not up for that, I just don't have the energy to do that. So now I'm going to go on to this issue of integrate development, and I will probably whip through some of this. This is just to remind you that we do see depression in younger kids, and there's some great work on depression in even very young kids that I'm not going to focus on today. But if you see by this slide, even though we see some depression, I've never been good with pointers. You can see, not very much depression in little kids, and then as you move into adolescence, it skyrockets, and then it gets pretty much what we see in adults, which is about 20% of the population. So what happens for adolescents? So we know that with puberty, there's a maturational changes in the brain that affect arousal, motivation, and emotions. And these changes are related to behavioral and emotional problems seen in adolescence. So the problems that are seen in adolescence, if you are an adolescent medicine care provider, adolescent doc, mostly the problems you see are problems that have to do with high-risk behavior. So substance abuse, reckless driving, reckless sexual behavior, suicide, self-harm, that kind of thing. Those are the problems that increase for adolescents. There's certainly a subgroup of adolescents who have chronic medical illness, but that is not the bulk of what's seen are the bulk of problems that we see in adolescence. The notion being that to help us figure out how to work with kids, we need to understand the trajectories, the brain development of reward responsivity. We know that part of this increase in risk-taking behavior has to do with a heightened seeking, if you will, for intense reward, which happens for adolescents. So what you and I may say, ooh, that's really risky, I'm not going to try that. If you were 16 or when you were 16, you might have said, ooh, that sounds really cool, I'm going to try that. So you've got a different kind of response to reward, and probably a different need for reward. There's a difference in terms of stress reactivity. We know that adolescents have a heightened intensity in terms of their stress reactivity, and certainly differences in affect regulation. And if we don't take these changes into account, then we are probably not informing our interventions effectively. So I'm not going to go through this, but trust me, there's a lot of data to support the fact that these changes happen. And I think that some of the data is particularly interesting. I'll just take an example. Sensation seeking, which we know is a really big deal for adolescents. I've just talked about that. It's associated with pubertal status, not with age. So if I'm 15 and haven't developed at all, and you're 15 and you're fully developed, we're going to differ on that, not because of our age, but because of our pubertal status. That's just one example. A lot of research to kind of back this up. So the adolescent brain is, there's differential development of subcortical and cortical systems. So our subcortical and cortical systems are equally mature when we're children and equally mature when we're adults. But adolescence has this period where things get a little bit out of kilter. And you get the prefrontal cortex, which people think about as the brakes, that, oh, this might not be a good idea. Oh, this might have a bad consequence. Ooh, I might get in trouble. That's your kind of prefrontal cortex. It's less mature than your subcortical cortex, which is the accelerator. Wow, this is a great idea. I can't imagine why skateboarding down this mountain doesn't make sense to me. Whew, I'm going to do it. So I think that we have this kind of imbalance, and we need to recognize it, respect it, understand it, and work with it. It's not the adolescent's fault, it's not the parent's fault, it's not the school's fault, it is just what it is. And then we know that the adolescent has this intensity of reactions, altered reward processing, risk-taking due to greater influence of the approach system, which I've just talked about, and all of these things may contribute to risk for depression. What I'm going to talk about now is this altered reward processing, because that's where we've done some research to focus on that. So motivated behavior has three distinct neural circuits. It's approach, which is striatum, avoidance, which is amygdala, and the regulatory, as we've talked about, is the prefrontal cortex. And here you see what happens for the adolescent in this course of development. Their prefrontal regions are getting there, but significantly, not nearly as fast as those more reactive aspects of their brain. So with depression, the transition for depression, so we think that adolescents are more sensitive to rewards, seeking more rewards, but we think what happens for depressed adolescents is that system turns off, shuts down. So depression is associated with deficits in reward motivation. And reward is really interesting, complicated of course, because there's different components to it. So there's, your reward can be wanting something. Our reward can be related to how pleasant or how happy you are with the experience. And this isn't a done deal by any means, but the research suggests that what happens in depression is difficulty anticipating that you're going to have a good time. Not necessarily if you get yourself into the situation, you might rate that you're having as good a time as other people in the situation. But if you're over here thinking, oh, I'm going to go to that party, or I'm going to call my friend, you're thinking, that is not going to be, what's the point? It's not going to be fun. I'm not going to do that. So that's where the reward problem happens. Again, there's data to suggest that this vulnerability to reward dysregulation is greater during adolescence. And this is a whole page of data to suggest different studies that have documented the fact that this reward processing is different for adolescents than it is for other age groups, including a whole series of fMRI studies. And I'm going to just talk about the last one for sake of time. I just heard about this one in October at a meeting, and Erica Forbes, who's at Pittsburgh, who's done some of the hallmark work in this area, she's done a lot of work in kind of fMRI tasks where, am I going to win this game? And it's kind of a monetary reward. And that makes sense as a task, a laboratory task that you can do in an fMRI. There's a lot of limitations because I think you have to be perfectly still and like this. But in any case, she's now expanded her work to develop some paradigms that include actually thinking about peers. So she's done a study where kids interact with their best friend. They bring their best friend into the lab. They talk about some events that they've shared in the past that they liked together, good things that they've done together. And then she does this fMRI processing where she finds that the more depressed the kid is, that is associated with a much more negative appraisal of the value or the reward of their activity with their best friend. So it is increased activation, in this case, in the amygdala. So I think she's just trying to prove that it isn't just a laboratory experiment, that if you actually have kids talk about these things and then you measure them in the fMRI, that they are showing differences in response. So response patterns and anhedonia. We focused our work on anhedonia. Remember, I told you that anhedonia is like a key feature of depression, social withdrawal, and difficulty having fun. If you think about anhedonia, it is associated with decreased motivation to obtain a reward. If we think about social withdrawal, it's going to be decreased frequency of reward-seeking behavior. And then fatigue or inactivity, which go with that, or decreased experience of rewarding outcomes. You're just not going to be there, so it's not going to happen. So this work has supported the fact that targeting anhedonia in the treatment of adolescent depression for at least some adolescents, those who are reporting lots of anhedonia, might be an effective target. This is just the RDoC model, and I think we can come back to it if people have questions. So to rapidly kind of go forward with this, what we've done is use behavior activation, which is a more behavioral intervention to try to test whether we can target anhedonia specifically with adolescents. This is kind of CBT without the T. It's very behavioral, and it came from work that Neil Jacobson did. It's been around for a while, but it came from work that Neil Jacobson did here at the UW a long time ago now, where he broke down CBT and said, what's really the effect? Is the effective component? Do you have to do the restructuring of thoughts, or is it just getting people active? And the activation piece was as effective as the whole CBT model. So then people have kind of revisited BA to kind of focus on getting people more actively re-engaged in their environment. So you can change how you feel by changing what you do. Focuses on 3 core strategies. Facilitative, it's just building a relationship. That's key to everything. And then activation, and then processes that inhibit activation, which is withdrawal, avoidance, and ruminative thinking, which is very common for adolescents. I'm going to kind of go forward here to talk about some other things. But we have tested this particular model with a group of adolescents. Our pilot study goal was it a feasible and acceptable approach, i.e. could we get people to do it? Would they come? Would they like it? Is it comparable to evidence-based practices for depression? And we set a very high bar in this study, probably foolishly, but it's too late. I think we could have set a lower bar and it would have looked snazzier, but we compared a BA approach to basically very skilled cognitive behavioral therapy. We had a few cases who were also very skilled interpersonal psychotherapy, so we weren't looking at treatment as usual, different from the two other things that we've talked about so far. So could we obtain an adequate treatment response? And then we wanted to explore this issue of activation as a factor. So 12 weeks, 14 sessions. Only thing I want you to take from this slide, this is just the demographics of the participants in this study, is that 57.6 and 57.84, those are high depression rating scores. These are people who have a significant level of depression, probably 15 points higher than the people in the group health study and probably 25 points higher than the people in the school-based work. So quite significant. The bottom line is that what we found is significant improvement in both groups, which might not sound ideal as a person thinking about an outcome, but that was actually what we were looking for. Could we match this up with established interventions? We did as well. That youth liked the model and participated. We had 83% completion rate for all participants, which is quite good for any psychotherapy study. Mean number of sessions attended was pretty equal for both groups, so we had people who were participating. It wasn't just and some people didn't get treatment, some people did, so 13.5 in BA and 12.6 in treatment as usual. And it shouldn't say treatment as usual because it is this much more skilled intervention. So what we found is that BA is a worthy approach of further consideration, and our next goal, our next step, is to, we have looked at the issues of activation. There's a scale for activation. And everybody got better in activation, which is also a good thing, but the BA kit, there wasn't a significant difference in the two groups. In terms of anhedonia, as has been found in other research, was the predictor of, significant predictor of how high your anhedonia was as you came in, predicted how depressed you were going to be at the end. But we did find that it mediated the association between initial depression and post-treatment severity depression for the BA kids, which means that we think we got some play with the BA approach in terms of some reduction in that anhedonia. So it's not a race. We need to integrate and develop this work. We're arguing now. We have to test. This is one of the challenges of doing the psychotherapy research in the current climate. You know, I said to you it takes 15 years or 20 years to get from the bench to the bedside. But the reality is it's very hard to figure out how to shortcut that process. So we're not even invested in BA as a standalone intervention, but we have to prove that it works as a standalone intervention to be able to argue effectively to sell it as a component of an intervention. So we're kind of in that little quandary. We are now trying to move forward by including actigraphy, which is when the kids are monitored for actually how much they're moving and what they're doing. We're thinking about a video game that they would engage in that has increased activation and mood in Pat Arian's work with older adults. And we are also moving forward to some fMRI work.
10 minutes.
Okay, so I'm going to give you 3 other quick things very quickly, and I'll just lay them out there and we can talk about them. So in addition to the things that we've done to kind of look differently, work differently in terms of treatment for depression, there's other strategies that I want you to consider, and that new approaches to treatment that take you in terms of implementation and study design. And these are going to be very familiar to many of you. The first is to take the modular approach, and that's what I was just edging into. We're not trying to, although we're doing this research on BA, we really think of BA as a potential module in a series of modules that you could apply. So if I assess those 3 kids that I presented to you early on, and I say, okay, this kid probably has some learning issues and needs to have some help with learning. This kid probably has some emotion regulation issues, and this kid is really struggling with anhedonia. I could formulate my treatment approach differently for each one. So for my anhedonic kid, I could start with BA. For that middle atypical depression kid with the peer things, I'd maybe start with interpersonal. And for both of them, I might eventually get to a little cognitive restructuring as I move forward. So John Weiss and his colleagues have tested this approach with pre-adolescents, and it was quite effective. And that's the modular approach. It's called MATCH. And you kind of come in, you figure out what's the main presenting problem. You start, say, down the line on doing your core modules to treat depression, but if it doesn't seem to be going right, or the parent comes in and says, this is all well and good, but my kid won't follow any directions at home and is getting kicked out of class, then you can, okay, we're going to regroup and we're going to do some work on behavioral management, parenting management, following directions, that kind of stuff, and then we'll come back to depression. So it's a very practical approach that you can bring in these modules and use them thoughtfully, planfully, not willy-nilly, but you're kind of working with the problems as they're being presented. Sometimes, particularly with depression, what gets you derailed is anxiety. I mean, depression and anxiety are like this. So you may have to stop and say, okay, I can see that you're depressed, but we've got to work on this anxiety about, I could say it'd be great. We can make all these plans about getting you active and making friends, but we've got to now take your social anxiety over here and do some work on that for you to get active and make friends. I can't just say to you, go out and introduce yourself and talk it up, That's not going to work. Wouldn't work for me. So I'm just putting in what I've already said about this modular approach, including these different components. I want to talk about 2 other options very, very quickly. So another option is to think about using what are called smart study designs. And I don't claim to have expertise, but I have great curiosity and am talking to people who have expertise in these smart study designs. And that's kind of a variation of what I've just talked about, which is instead of me saying, okay, I'm going to take my 2 kids, all meet the same criteria, these kids go into BA, these kids go into cognitive behavioral therapy, they all get treated for the whole course of the intervention, and then we see what happens at the end. With a smart study design, you might take a kid who presents with social withdrawal, and you might say, okay, I could treat that kid in an IPT kind of social communication way, or I could treat them in a BA reward exposure way. So I divvy my kids up, put them in those 2 little categories, maybe do 4 to 6 sessions. That's obviously, you can determine that. Do a reevaluation what they're doing, and then maybe have them go on to do another component. So it's kind of how you test these modular component versions. So you're testing out different combinations of interventions with different kids, depending on how they're responding to what you're offering them. So that monitoring of treatment and symptoms and function is critical. It means that you can do briefer interventions, switch things up more quickly. Your ultimate intervention might not be briefer, but you're not necessarily waiting to the bitter end to figure out, oh, did they respond or they didn't respond. You're looking, if they didn't respond, here's how I'm tweaking this, here's what I'm going to do next. And obviously in a research design, you're doing that in a structured, thoughtful manner. So this is a good to explore things like what's your optimal dose, and then using individual characteristics to determine where to start, and then what to do if there's no response. And then the last thing, and I won't talk much about this, is a really interesting approach that folks down at University of California at San Francisco are proposing, and that is, again, using this RDoC approach to do an intervention for these atypical depressed kids. And they have a wholly different model than what we would use for the anhedonic kids. We're talking more about striatal lack of reactivity, and they're talking about amygdala instability. And so they are seeing that the drivers of depressive pathophysiology is sustained threat, wakefulness, and loss, and they have specific interventions, very behavioral, not what you would see in a CBT manual or IPT manual. So they're talking about breathing and yoga. We might pilot some of this work with them. So I'm trying to find a yoga instructor, if anybody has a yoga instructor who wants to do some of this. They're talking a lot about cognitive reappraisal, which we talked about. This is a treatment approach that hasn't been tested yet, but is probably the first thing I've seen that has really walked us through all these RDoC and all the brain development research on adolescents. And they've chosen to focus on these atypical kids. We've chosen to focus on these anhedonic kids, so we're hoping that we can work together to kind of move this forward. So I'm going to stop. There you go. Thanks for your attention. There's a lot you could do. Questions or comments or disagreements? Yeah. Okay, I'm going to try to repeat and correct me if I don't get it right. So your point is that research suggests that short-term rewards work better than long-term, but parents tend to use long-term rewards, emphasize long-term rewards. And any strategies to kind of work on that?
Yes.
Is that
Especially adolescents with depression.
right? So I think it's a really important and very practical question. I love this question because it is critical. You can't, I think parents, probably myself included, when I still had kids at home, were like, you're graduating from high school or something way out there, and it really has to be right in the moment. And so I think you have to teach parents and kids themselves how to structure their behavior so that there's kind of an immediate reward built in, that they've identified something. Depressed kids are very bad at rewarding themselves. So at least in the behavioral activation approach, we do a lot of what are you going to do, when are you going to do it, who are you going to do it with, what are going to be the obstacles to doing it, and how are you going to reward yourself for at least trying to do it. And then I think you need to really work with parents to educate them, just to educate them to the points that you made, that it's very important. Yes, we're all in favor of those long-term rewards, but if we have a kid who isn't experiencing many things as rewarding, our goal is to get them as much as exposure as possible to small steps of rewarding things, and then to kind of support them in savoring the reward that they're experiencing. So our sense is if we can get these depressed adolescents into a rewarding situation, they tend to actually feel okay about what happens. That isn't 100%. That's why I'm being hesitant, because it depends obviously on the situation. And some social situations are so fraught with anxiety that they aren't very rewarding. So you have to choose your situations very carefully. But you have to build very slowly, particularly for a very unmotivated or socially anxious adolescent. Or you'll overwhelm them and they won't do anything. So I think I'm just really agreeing with you, but I think working with parents and kids themselves to break it down and be specific. And the other thing that we do with parents is really talk with them about how you figure out and listen to your adolescent to figure out what is rewarding for them. So parents will say, yes, I reward him. I ask him every day, can I help you with your homework? Not rewarding to most adolescents. You need to be thinking about, ask the adolescent what would be rewarding. It might be rewarding if you had in the house my favorite snack, or if you kept my little brother out of my workspace just long enough for me to do my homework, or if you left me alone. That is one that's frequently stated. So I think it's what is rewarding. We make assumptions. What's rewarding for you isn't going to be rewarding for me, and that really is true for adolescents. Well, anxiety, again, has many faces. So there's some kids who have a lot of social anxiety, so that's going to interfere with them feeling reward in a situation. And certainly anticipating getting engaged in a situation, because if I think it's going to be really fun to hang out with you, I might get my homework done, or I might do whatever, and I might get there. If I think this is going to go badly and she's not going to like me and I'm going to make a fool out of myself, all that rumination that can go on, I'm not going to get myself to that interaction with you. I'm going to avoid it. So anxiety is true for some kids, but not every depressed kid has social anxiety. So you just have to really be teasing that out.
So do you think a pair or both?
getting them to do the rewarding thing in the first place is the first step. And now I'm really speaking from this BA model, so most of these questions are about that kind of model. So it's really critical in the BA model that it isn't just pleasant event scheduling, which is part of a lot of cognitive behavioral approaches. I really need to work with that adolescent to figure out what's rewarding for them. And when I know what's rewarding for them, then we've identified what's rewarding for them, then we have to build in those activities. So it's not ever making an assumption that you as a therapist are never making the assumption that hanging out with your friends is rewarding, because it is for some kids, it isn't for other kids. And you just need to be finding what are the things that are going to be rewarding for them, and then helping them to kind of overcome the obstacles to engage in that. It could be going to class, it could be doing homework, it could be talking to their parents. I mean, who knows? It could be playing the guitar. Everyone seems to hang on to the computer games, whether they're rewarding or not. They seem to fill the void for most kids, so they still do those. Yeah, no, we did not rule out kids who had an anxiety disorder, who had oppositional defiant disorder, who had conduct disorder that wasn't going to mean that they wouldn't come to treatment. Some conduct disorder kids aren't going to sign. Well, they take themselves out because they don't sign up, but. In our study of it, and I think as we move forward, I think I don't think, that's a really important point also, I don't think as we move forward to study depression, we can continue to do any studies where we're ruling out half the population. So we have to deal with comorbidities. So we had suicidality, we had substance use. Again, there's a point in that intervention where, as any good practical clinician, if you feel like this problem's gotten out to the top of the problem list such that I can't deal with anything else, and you have to deal with substance use or those kind, or suicidality. We probably had some kids who had eating disorder, but probably not full criteria. Certainly that was going to, because eating disorder is another little noisy one that kind of. Disordered eating, I think, is what I would say, is another noisy one that gets in there. Not anorexia, but a lot of things about food. And so I think any intervention study at this point in time has got to have a pretty wide open door, or else we're not teaching people anything. We're not learning anything, because those little finely tuned depressed kids are few and far between. 90% of them have another diagnosis.